Welcome, and thank you for joining us for today's deep dive. We have an incredibly fascinating journey ahead of us
I
today.
really do.
Yeah, we're exploring a comprehensive collection of clinical sources entirely dedicated to pediatric cardiovascular disorders. And our mission for this deep dive is to decode the incredibly complex, almost um, magical plumbing of the tiny human heart.
The plumbing really is magical when you get down to it.
It is.
Yeah.
We're going to look at how it adapts while a fetus is still in the womb, the wild anatomical workarounds when the blueprints go wrong, and the fascinating ways modern medicine just, well, hacks the entire system to save lives.
Right.
Even if you aren't actively managing patients on a pediatric floor, understanding these mechanical miracles and the clinical fixes, it will give you a whole new appreciation for the engine ticking inside your own chest right now.
It really is a marvel. I mean, when you think about the heart, it's tempting to just picture a simple mechanical pump. But the pediatric heart, especially during that critical transition from fetal life to birth,
Yeah.
it's a highly dynamic, adaptable machine. The clinical material we are analyzing today paints a vivid picture of just how delicate yet resilient that organ is.
Definitely.
If we connect this to the bigger picture, the overarching theme of pediatric cardiology is that the heart is entirely at the mercy of pressure gradients.
Hmm.
It all comes down to fluid dynamics and how the body manipulates those pressures to survive.
And to really grasp the pathology, we first have to understand the original blueprint. So let's start with a mind-blowing physiological reality. When you are a fetus, you do not use your lungs to breathe.
Right. You just don't need them yet.
90% of your blood volume completely bypasses the pulmonary circuit. Instead, the placenta acts as the primary organ of respiration.
The fetal lungs are essentially just growing tissue at that stage. They don't need a massive high-pressure blood supply yet because they aren't oxygenating anything. The placenta is doing all the heavy respiratory and filtration lifting.
Right.
To make this bypass system work efficiently, the fetal heart comes equipped with what we can think of as 3 secret doors: specialized anatomical shunts.
I love that analogy. 3 secret doors built into the plumbing.
Yeah. The first is the ductus arteriosus. This is a vital vascular pathway connecting the pulmonary artery directly to the aorta. Instead of the right ventricle pumping blood into the lungs, the blood takes this detour straight out to the systemic circulation.
Okay.
The second door is the foramen oval. This is a small flap or opening located directly in the atrial septum. It allows blood entering the right atrium to skip the trip down to the right ventricle entirely.
And cross straight over to the left atrium.
Exactly. And the third is the ductus venosus, which is a vascular pathway bypassing the hepatic system because the placenta has already filtered the blood before it even reaches the fetus.
Okay, let's unpack this. So you have this highly specialized, intricate system of bypasses, keeping the fetus perfectly oxygenated in utero. But then the magical moment of birth happens.
Everything changes.
Everything.
Yeah.
And normally, within hours or days of a neonate taking its first breath, the physical clamping of the umbilical cord and the sudden expansion of the lungs completely alters the pressure gradients in the chest.
Yes.
Those secret doors are triggered to slam shut, and the baby's heart suddenly has to function like a normal compartmentalized pump. But the big clinical question we are tackling today is, what happens to the patient when those doors refuse to close?
That is exactly where the fluid dynamics become a massive clinical problem. In a healthy, fully transitioned heart, the left ventricle is a powerful, thick, high-pressure muscle.
Its job is to overcome systemic vascular resistance and pump blood to your entire body.
Right. While the right ventricle is a lower pressure system designed only to gently push blood right next door into the pulmonary bed. In cardiology, when blood takes a wrong turn because of these abnormal openings, we call it a shunt.
So if there's a structural leak between these two sides, the sheer physics dictate that the high-pressure left side is always going to overpower the low-pressure right side.
It forces the blood backward.
The clinical term for this is a left-to-right shunt, which results in increased pulmonary blood flow, basically leaky pipes flooding the lungs.
The clinical presentation reflects that perfectly. Let's look at patent ductus arteriosus, or PDA. Patent simply means the structure remains open.
So that first secret door we mentioned.
Yes, the bypass connecting the pulmonary artery to the aorta, it fails to close after birth. This is an incredibly common complication if you are dealing with premature infants.
Because the left side of the heart is pumping with such force.
Oxygenated blood actually flows backward from the high-pressure aorta through that patent ductus and floods the lower-pressure pulmonary circulation.
And if you're at the bedside, the symptoms are exactly what you'd expect from fluid overloading the lungs. You'll hear crackles upon auscultation, the infant will exhibit tachypnea, and they experience profound fatigue just from routine feeding.
It's exhausting for them.
The clinical notes specifically highlight that these babies might actually experience diaphoresis sweating while feeding, because the metabolic demand of trying to eat while essentially drowning in their own pulmonary fluid is just so exhausting.
The metabolic toll is immense, and you see similar physiological stress with septal defects, whether it is an atrial septal defect, an ASD, or a ventricular septal defect, a VSD.
Where there's a literal hole between the upper or lower chamber.
Exactly. When you have a septal defect, you are losing that vital pressure barrier between the chambers. The VSD is actually the most frequently diagnosed congenital heart defect.
Wow.
In all these cases of left-to-right shunting, you have oxygenated blood needlessly recirculating through the right side and getting slammed back into the lungs. It forces the right ventricle to hypertrophy from the massive workload.
So if the problem is a physical door that won't close, my mind immediately jumps to a surgical suite and open heart surgery. But there's a wild chemical workaround here for the PDA, right?
There is, and it's a brilliant piece of pharmacology. Instead of immediately rushing a fragile premature infant to the OR, clinicians can use a targeted chemical hack.
Okay.
They administer NSAIDs, specifically medications like indomethacin, ibuprofen, or even intravenous acetaminophen. These drugs work by inhibiting prostaglandin synthesis.
Because prostaglandins are the specific chemical messengers that keep that ductus open in utero.
Exactly. By blocking them with common painkillers, you can chemically force that vascular pathway to constrict and permanently seal.
It is a targeted plumbing sealant delivered through an IV. That's incredible.
It really is.
It is amazing that everyday medications have such a profound structural impact. But those left-to-right shunts, the leaky pipes, they usually leave a baby looking pink because oxygenated blood is still circulating out to the body, even if the system is wildly inefficient.
Right.
Let's pivot to the opposite end of the spectrum. Decreased pulmonary blood flow. This is where we see the severe cyanotic conditions historically referred to as blue babies.
The mechanics completely flip in these scenarios. The classic example in pediatric cardiology is tetralogy of Fallot. As the name implies, the neonate presents with 4 simultaneous structural defects.
4 of them.
Yeah. But the primary drivers of the pathology are a large ventricular septal defect combined with severe pulmonary stenosis, a critical narrowing of the outflow tract to the lungs.
And because that pathway to the lungs is physically obstructed by the stenosis, the pressure dynamics we just talked about are thrown into chaos. The pressure in the right ventricle becomes so massive trying to push past that blockage.
It actually overtakes the pressure in the left ventricle.
So instead of a left-to-right shunt, we get a right-to-left shunt.
The physiological consequences of that reversal are immediate and severe. Deoxygenated blue venous blood is forced from the right ventricle straight through the VSD into the left ventricle and gets pumped out into the systemic circulation without ever passing through the pulmonary bed to pick up oxygen. This systemic circulation of unoxygenated hemoglobin causes profound cyanosis. The infant's skin, nail beds, and mucous membranes will literally take on a bluish hue.
Here's where it gets really interesting. The clinical texts detail a terrifying sudden exacerbation of this condition called a TET spell, or a hypercyanotic episode.
Those are very scary.
When a baby with tetralogy of Fallot gets agitated, feeds, or starts crying, their oxygen demand spikes, and they can suddenly turn deep blue, lose consciousness, and potentially code. But the immediate first-line intervention for a TET spell isn't a high-tech medical device or a complex drug.
No, it's not.
If you're dealing with a toddler, you teach them to squat down. If you're managing an infant, you physically push their knees firmly up to their chest.
The sheer physics of that intervention are brilliant. What's fascinating here is that by squatting or forcing the knees to the chest, you are physically compressing the femoral arteries and the massive vascular beds in the legs. This mechanical compression massively increases the systemic vascular resistance. It essentially creates a high-pressure traffic jam in the lower systemic circulation.
Right.
That spike in left-sided pressure forces the blood back up toward the heart, overcoming that right-to-left shunt and pushing blood back across the VSD toward the pulmonary artery so it can finally get oxygenated.
It is a purely mechanical anatomical hack to break a life-threatening cycle.
It is.
It's just incredible that a natural, instinctual behavior like a toddler squatting perfectly manipulates advanced vascular resistance physics. And the medical hacks don't stop there. The sources detail another profound condition called tricuspid atresia.
Right, where the tricuspid valve is simply absent.
There's a solid wall of tissue where the valve should be, meaning blood literally cannot get from the right atrium to the right ventricle to reach the lungs.
In these severe cases of decreased or absent pulmonary blood flow, the clinical strategy completely reverses. Those secret fetal doors we talked about earlier. The clinical team absolutely must keep them open. If the ductus arteriosus closes in a patient with tricuspid atresia, the patient will immediately lose their only pathway for pulmonary blood flow.
So to artificially hack the system, clinicians will put the neonate on a continuous intravenous drip of prostaglandin E, or PGE.
Exactly. We mentioned earlier that we use indomethacin to block prostaglandins and close the ductus. Here, we are artificially flooding the infant's system with synthetic prostaglandin E.
Reversing the process.
Yes. It is a potent vasodilator that chemically paralyzes the smooth muscle of the ductus arteriosus, preventing it from constricting.
If you are a nurse managing that patient, your eyes are glued to that IV pump. The clinical guidelines emphasize that this drip cannot be interrupted for even a moment.
Not even for a second.
If that IV line occludes, or if the syringe runs out while you're waiting for the pharmacy to mix a new batch, that ductus will begin to spasm and close within minutes. You are chemically holding the door to the lungs open, keeping that child alive minute by minute until the surgical team can intervene.
It highlights the razor-thin margin of error in pediatric cardiology. But so far, we have been discussing shunts blood leaking or bypassing through abnormal pathways. We need to shift our focus to what happens when the primary pipes themselves are structurally deformed.
So we've been talking about holes and leaks, but what happens when the plumbing isn't just leaking, but is completely pinched off, or worse, installed entirely backward?
Right.
Let's look at the obstructive disorders first. Coarctation of the aorta. The aorta is the primary superhighway carrying oxygenated blood to the body, and in this condition, there's a severe, localized narrowing, like a sharp kink in a garden hose.
The diagnostic approach to a coarctation is an elegant exercise in physical assessment because the stricture typically occurs just distal to where the arteries branch off to supply the head and upper extremities, but before the descending aorta heads down to the lower body.
The pressure dynamics are split.
Exactly. If you are monitoring this patient, you aren't just looking at the telemetry monitor. You have to physically perform 4-point blood pressure checks, measuring the pressure in both arms and both legs simultaneously.
And you are looking for a stark, undeniable contrast. Because of that kink, the blood pressure in the upper extremities is going to be incredibly high. The vessels in the head and arms are bounding.
Yes.
But the blood pressure in the lower extremities will be significantly lower, accompanied by very weak or even absent femoral pulses. The clinical standard is looking for a pressure gradient difference of more than 20 millimeters of mercury between the arms and the legs.
It's a direct physical manifestation of that internal vascular traffic jam.
Definitely.
But if we want to talk about the most extreme anatomical error discussed in the sources, we have to look at transposition of the great vessels. This is the ultimate crossed wire scenario. The two major arterial trunks leaving the heart are literally swapped.
It sounds like an absolute physiological nightmare. The right ventricle, which usually pumps to the low-pressure lungs, is mistakenly plumbed directly to the aorta, pumping deoxygenated blue blood endlessly out to the systemic circulation.
Right.
Meanwhile, the left ventricle, which usually pumps to the body, is connected directly to the pulmonary artery, endlessly pumping perfectly oxygenated red blood right back into the lungs. You are left with two completely separate, parallel, closed loops that never interact.
It is a profound, immediate cardiac emergency the second the umbilical cord is clamped. The neonate will be profoundly cyanotic and completely unresponsive to supplemental oxygen because the oxygenated blood literally has no anatomical route to reach the brain.
Unbelievable.
And what's fascinating here is the paradoxical survival mechanism. For a neonate to survive this for even a few hours, they absolutely must possess another heart defect. They require a concurrent ASD, VSD, or a widely patent ductus arteriosus. They need a structural flaw somewhere in the system to allow those two separate loops to mix, permitting at least a fraction of oxygenated blood to cross over into the systemic side.
And if they don't have a convenient septal defect?
The interventional cardiologist will create one.
Right. The literature describes the Rashkin procedure, or a balloon atrial septostomy. A clinician will thread a balloon-tipped catheter up through the femoral vein, into the heart, push it forcefully through the foramen oval into the left atrium.
Inflate the balloon.
Inflate it, and then violently yank it back to intentionally tear a massive hole in the atrial septum. They are intentionally inducing a traumatic heart defect to facilitate vital blood mixing, buying the infant enough time to reach the operating room,
where surgeons will undergo the monumental task of physically detaching the great arteries and transposing them back to their correct anatomical positions.
It is an absolute masterclass in emergency physiological adaptation and interventional courage. But everything we have analyzed so far falls under congenital defects, structural anomalies present at birth.
Yes.
The clinical material also takes a hard pivot into acquired heart diseases. These are post-birth invaders that fundamentally destroy previously healthy pediatric cardiovascular tissue.
And the first acquired condition detailed is truly a cautionary tale of compounding pathology, rheumatic heart disease. This doesn't originate from a complex genetic anomaly or a developmental failure in utero. It starts with something incredibly mundane, a simple case of strep throat.
Specifically, an infection caused by group A beta-hemolytic streptococcus.
Right. If that primary infection goes untreated, or if a patient fails to complete their full course of antibiotics, the bacteria don't simply remain localized in the pharynx. Approximately 20 days post-infection, an abnormal autoimmune response is triggered. The body's antibodies, initially designed to attack the strep bacteria, begin cross-reacting with healthy connective tissues across the body. This triggers a massive systemic inflammatory cascade known as rheumatic fever.
If you are assessing a child with rheumatic fever, the clinical presentation is bizarre and severe. The sources detail profound polyarthritis, severe joint pain that migrates from joint to joint, subcutaneous nodules popping up under the skin, and Sydenham's chorea,
which presents as these sudden, uncontrollable, jerky movements of the extremities and face.
But while those symptoms are terrifying to witness, the real danger is silent and significantly delayed. This systemic inflammation aggressively targets the endocardium, the inner lining of the heart.
It does.
Up to 15 years later, this localized inflammation results in severe, permanent scarring and stenosis of the mitral and aortic valves. A missed sore throat diagnosis when a patient is 7 could dictate the need for a mechanical heart valve replacement in their 20s.
It perfectly illustrates why strict adherence to antibiotic regimens is a non-negotiable clinical standard. But while rheumatic heart disease is tied to a bacterial vector we deeply understand, the next acquired condition in the material is much more idiopathic. And frankly, alarming: Kawasaki disease.
Kawasaki disease is an acute multi-system vasculitis, a severe inflammation of the blood vessels. Initially, its presentation mimics relatively benign childhood illnesses, which makes it tricky to diagnose.
Very tricky.
A toddler will suddenly spike an unyielding high fever lasting for days, accompanied by highly distinct dermatological symptoms. A polymorphous rash, bilateral conjunctivitis without discharge, a swollen, bright red strawberry tongue, deeply fissured red lips, and profound erythema and edema of the hands and feet.
That eventually leads to the skin peeling off in sheets.
Yeah.
The superficial symptoms are deeply distressing for both the patient and the parents. However, the true clinical terror of Kawasaki disease lies beneath the surface. It is the leading cause of acquired pediatric heart disease in the developed world. The aggressive vasculitis specifically targets the cardiovascular system, and alarmingly, it is one of the very few pathophysiological mechanisms that can cause a previously healthy toddler to suffer a massive myocardial infarction.
A toddler suffering a full-blown heart attack.
Wow.
The clinical stakes are almost unimaginable.
It occurs because the severe inflammation severely weakens the walls of the coronary arteries, the vital vessels supplying oxygen to the heart muscle itself. This weakness leads to the formation of massive coronary artery aneurysms.
The vessels balloon outward,
creating pockets where blood flow becomes sluggish and turbulent. If a massive thrombus forms in one of those aneurysms and occludes the artery, or if the aneurysm simply ruptures, the child suffers an acute MI.
That's terrifying.
The clinical data notes that without rapid intravenous immunoglobulin therapy, coronary artery aneurysms develop in over a quarter of affected children.
And the pharmacological intervention for this flips the standard rules of pediatric care completely upside down. Usually, administering aspirin to a child with a viral-like fever is strictly contraindicated due to the risk of Ray's syndrome, a potentially fatal encephalopathy.
But for Kawasaki disease, the threat of a coronary thrombosis is so immediate that clinicians prescribe massive high-dose aspirin regimens.
They are utilizing the aspirin not just for its anti-inflammatory properties, but heavily relying on its potent antiplatelet effect to thin the blood and prevent clots from forming inside those ticking coronary aneurysms.
Exactly. The clinical guidelines also explicitly mandate that before a pediatric patient with Kawasaki disease is discharged, the parents must be formally trained in infant and child CPR.
That discharge requirement alone underscores just how critical and volatile the recovery period is. The threat of sudden cardiac arrest follows them home. This naturally transitions us into the final, sobering section of the clinical data. We've analyzed the structural shunts, the obstructive kinks, and the destructive acquired vasculitis. But what is the ultimate physiological endpoint when these medical interventions aren't enough, or when the sheer workload overwhelms the muscle?
When it all fails.
So what does this all mean when the system finally buckles? The sources lay out the ultimate consequence: congestive heart failure, or CHF. This is the critical threshold where the cardiac output simply cannot meet the basic metabolic demands of the body's tissues.
And if you are monitoring a patient in failure, the specific symptomatology depends entirely on which side of the pump is giving out. In right-sided heart failure, the right ventricle can no longer push blood forward into the pulmonary artery effectively,
Because of that lost forward momentum.
the fluid backs up into the systemic venous system. You will observe profound hepatomegaly, an enlarged liver, and severe peripheral edema, presenting as swelling in the face, hands, and lower extremities.
And on the other side,
Conversely, in left-sided heart failure, the left ventricle fails to empty effectively, causing the blood to back up into the pulmonary veins, leading to severe pulmonary congestion, flooding the alveoli, and causing those distinct crackles and profound respiratory distress we discussed with the left-to-right shunts.
the ultimate terminal system failure, though, is shock. The material categorizes three primary mechanisms. There's hypovolemic shock, driven by a critical loss of actual intravascular fluid or blood volume.
Right.
There's cardiogenic shock, where the myocardial tissue is simply too damaged or exhausted to generate a contracting force. And there's septic shock, where an overwhelming systemic infection triggers a massive inflammatory cascade, causing profound vasodilation. Every blood vessel in the body widens simultaneously, and the systemic blood pressure essentially drops to zero.
And even in the face of profound shock, alongside the aggressive administration of 5E fluids, vasopressors, and inotropes, there is one final, brilliantly simple physical intervention detailed in the protocols. Clinicians will utilize basic gravity to their advantage by placing the child in the Trendelenburg position.
That is the clinical maneuver, where the bed is physically tilted so the patient's feet are elevated significantly higher than their head.
Yes.
If the central pump is failing and the vascular resistance has collapsed, you literally use the pull of gravity to shunt whatever residual blood volume is left in the lower extremities back down toward the core, prioritizing perfusion to the brain and major organs to sustain life.
When you strip away all the advanced pharmacology and the complex surgical techniques, pediatric cardiology repeatedly circles back to fundamental physics: pressures, anatomical shunts, vascular resistance, and gravity.
It really is a masterclass in biomechanics. As we wrap up this deep dive, it is impossible not to be awestruck by the sheer resilience of the pediatric cardiovascular system. We have seen the ingenious ways modern medicine intervenes, whether clinicians are utilizing common SIIs to chemically seal off fetal bypass pathways, performing violent catheter procedures to tear open atrial septums to buy time, or just utilizing the basic mechanics of a toddler squatting to reverse a life-threatening lack of oxygen.
It's amazing.
It reminds you just how beautifully complex and precariously balanced our internal plumbing is engineered.
The clinical balance is incredibly delicate. But the advancements in pediatric interventional cardiology and pharmacology over the last few decades have been nothing short of miraculous. The medical community is routinely sustaining and repairing lives today that would have been universally lost just a single generation ago.
Which actually leads me to a final provocative thought I want to leave you with today. We've talked extensively about how these severe structural defects are hacked, bypassed, and surgically corrected in early infancy.
We have.
But consider the long-term reality of these successes. Because these highly advanced, life-saving pediatric surgeries are a relatively recent triumph in the timeline of medical history, we now have an entirely brand new generation of patients surviving well into adulthood.
That's a great point.
As these surgically modified, extensively replumbed pediatric hearts age into their 50s, 60s, and beyond, what entirely unprecedented, never-before-seen physiological challenges are they going to present to adult cardiologists who are suddenly encountering these childhood anatomical hacks for the very first time?
That is a whole new frontier.
It is something fascinating to ponder the next time you feel your pulse. Thanks for joining us, and we'll catch you on the next deep dive.